This patient has a class 3 airway. I hope that I can get the intubation on the first attempt, but I have the glide scope in the room just in case.
That's good. Did you check your equipment is functional?
Yes.
Okay, and what size of endotracheal tube have you decided on?
I chose a size 7.
Very good. Remember, an appropriate endotracheal tube size depends on the patient's size, the patient's age, his body habitus, and the type of surgery.
Okay. I'm going to induce now.
Okay?
Thank you. Now I will inflate the cuff.
Very good. I will give a few breaths.
Okay. Very good.
Okay. I'm going to take the tube and you go ahead and document.
Thank you.
Mm-hmm.
Huh. Now, what does it mean inflated with a minimum volume to create seal? I used 10 cc's. Is that enough?
Well, that's a good question. That actually may be more than enough. The cuff should be inflated just to the point of obtaining a seal in the presence of 20 to 30 centimeters of water pressure.
Okay, well, the more the merrier, right?
No, that's not correct.
Huh.
How do you know when enough is enough? What do you gain when you just give minimal amount of air into the cuff?
Well, the book says when I create a cuff pressure of 20 to 30 centimeters of water, that's enough to create a sufficient seal.
How do you get that and how do you check for it?
Well, too much air can cause the tube to compress the trachea, leading to trauma. It can take only 15 minutes for high cuff pressures to cause damage. Among some serious and rare complications are tracheal rupture, necrosis, and stenosis, which are all sequelae of too much pressure being applied to the trachea from an endotracheal tube. Tracheoesophageal fistula or laryngeal nerve palsy are also possible.
Very good. It looks like you've done your reading. Even if these complications are unlikely in our case, you have to remember that post-intubation sore throat is a common side effect of intubation and may partly result from temporary ischemia of the oropharyngeal and tracheal mucosa.
Okay, well that's great to know, but how do I know when enough is enough?
Palpation of the pilot balloon is to estimate cuff pressure is controversial at best. Some clinicians use a monitor to maintain cuff pressures. In practice, most clinicians use other methods to determine cuff pressure in the operating room. There are two methods used. The one is the occlusion pressure technique. The second is the minimal leak technique. While both of these techniques vary in exact execution, they basically involve gradual inflation of the cuff to the point where there is no leak or minimal leak seen or auscultated. Here, let's practice. The first method we are going to demonstrate is the minimal occlusion pressure technique.
Okay. So, how do we do that?
Okay, we will first place the patient on the ventilator and we will look here at the pressure in centimeters of water.
Okay.
Our goal is to inflate the balloon to the point where you get no leak at 20 centimeters of water. So deflate the cuff.
I will deflate the cuff.
Okay, now inflate the cuff until it reaches 20 centimeters of water. There you go. Now it has reached 20 centimeters of water. You can also check to see that the tidal volume set on the ventilator matches the tidal volumes delivered to the patient.
It matches.
Very well. A second method is called the minimal leak technique. This method, you use the stethoscope. We will deflate the cuff for demonstration. Place your stethoscope on the neck, and I will inflate the cuff until you until you hear the most minimal leak.
Okay, I no longer hear a leak.
Okay, very well. This is the amount that's required for this patient.
Okay, great. Well, are there any situations where cuff pressure changes over the course of an operation?
That's another good question. Cuff pressures can change after initial inflation. Initial factor is the inhaled nitrous oxide. Inhaled nitrous oxide can diffuse into the tracheal tube cuff that has been inflated with air, causing more compression on the airway. Pre-inflation of the cuff with a 50% nitrous oxide oxygen mixture rather than with air prevents the buildup of excessive cuff pressures and significantly reduces cuff site injury. But this is not practical. Some even recommend checking the cuff every 20 to 30 minutes when anesthesia with nitrous oxide is being used. Another factor is the rising peak airway pressures during mechanical ventilations during specific operations. Rising peak airway pressures require high cuff inflation pressures in order to prevent a cough air leak. Please consider this during cases where you expect peak pressures to increase, for example in laparoscopic surgery. Last but not least are retractors used during neck surgery, which can increase the cuff pressures up to 90 centimeters of water. This is why you may have to release some of the air during this period of the surgery.
Well, I'm glad you were here for this intubation. I will definitely keep all of this in mind. I had no idea there was so much to consider when inflating the endotracheal tube cuff. Awareness is definitely the place to start, and I'm glad it started for me now.
Good, I'm glad you had a good learning lesson today.
Thank you.